Welcome to the Reproductive Justice, Disparities of Maternal and Fetal Health event organized by Crystal Nova. You can see her up here pinned. She is a third-year law student at Loyola University Chicago School of Law, and me, Jessica Simpson, a third-year medical student at Loyola University Chicago Stritch School of Medicine, and the founder of White Coats for Black Lives chapter at Stritch. I'm also a JANU student ambassador, so all of you guys are going to receive 25% off for attending today, so expect an email from me if you want to purchase scrubs at a discounted rate. And thank you all so much for joining us. We're really excited. I'm incredibly thankful for this opportunity to engage in meaningful conversation with all of our panelists and with all of you, especially about this very important social and reproductive justice issue. Just because normally we would do this in person, we're going to ask if everyone can turn on their camera if you feel comfortable to do so. Right now, everyone is on mute, but during the Q&A session, you'll be able to unmute yourself and ask your question if you want to, or you can type your questions in the chat. I'll be reviewing that, okay? So tonight we're going to begin with a 40-minute discussion with our panelists, followed by a 15-minute Q&A session with all of you. Again, please feel free to type your questions in the chat for those few of you that have just joined us. I was just explaining that everyone can turn on their camera if they would like to, because we normally would be doing this in person, right? But feel free to write your questions in the chat, and I'll be monitoring that throughout the session, and then I'll select a few questions during the Q&A session, okay? And we'll also allow for you guys to ask your question if you want, so just kind of like raise your hand, turn your microphone off during that time, and you can go on ahead and ask your question. Then we'll wrap up the event with a few reminders and also about some things that all of us can do to address these important issues. And with that, I'm going to turn it over to my colleague, Crystal.
Hi, everyone. So as Jessica said, I am a 3L in Loyola's University School of Law. I am with the Health Justice Project. And we're just really honored to have our three amazing speakers today. Tonight, you'll be hearing three brilliant leaders in law, medicine, and community-based doula services. I'm really excited to bring this conversation forward. Each of our panelists is actively working to dismantle the stigmas and stereotypes that give rise to disparities in maternal and fetal health. So first on our panel, we have Amy Chen. Amy has received her BA from Stanford University and also her JD from Harvard Law School. Her areas of expertise include reproductive and sexual health, pregnancy coverage, maternal health, and Medicaid coverage for doula care. Prior to joining the National Health Law Program, Amy worked as a legal aid attorney in Oakland, California for 8 years. Next on our panel, we have Dr. Robin L. Jones. Dr. Jones has allowed us to graciously call her Robin throughout the Q&A session, so thank you for that, Dr. Jones. Dr. Jones is an obstetrician-gynecologist and assistant professor with Rush University Medical Center. Dr. Jones attended the University of Texas Medical School at Houston, and she completed her obstetrics and gynecologist residency at State University of New York. Dr. Jones's scholarly work focuses on national partnerships for maternal early warning criteria and an examination of the Illinois Obstetric Hemorrhage Project. We're excited to have you, Dr. Jones. And then on our panel, we also have Tayo Mbande. She is the founder of Chicago Birthworks Collective, which is a Chicago-based organization providing full service, full circle care for Black women, birthing women, and their families in Chicago. Tayo is a graduate from Howard University. She is WIC trained and a breastfeeding peer counselor. And in 2017, she became an SMC full circle doula birth companion. So Tayo works in Chicago to empower families through their pregnancy journey by providing trained doulas and birth workers to support and offer education. So we're really excited to have everyone here today. We encourage all questions through the chat. I'm ready to get this started. So at this point, we will dive into questions that Jessica and I have developed with law school organizations as well, the Health Law Society and the Black Law Students Association, to address the importance of reproductive justice and discuss some of the issues related to disparity and identify solutions on how we can all improve maternal and infant health. Before we get started, can you please briefly discuss your work? And this question is directed to all, but we're really focusing on what brings you to your work. How does your work address maternal and infant health disparities? And I can start that question with Amy.
Sure. Thank you, Crystal, and thanks again for having me. As Crystal mentioned, I'm a senior attorney with the National Health Law Program in Los Angeles, where I work on various issues of reproductive and sexual health, but in particular around pregnancy coverage and maternal health. I would say for the past few years, one of the big projects that I've been working on is trying to help support doulas and advocates in other states around expanding access to Medicaid coverage for doula care. So that's actually rolling out in Illinois, where you all are, as well as California, where I am. So super exciting. And I was kind of looking at Medicaid coverage for doula care in terms of kind of what brought me to that work. So I think, as Crystal mentioned, I used to be a legal aid attorney in Oakland for 8 years before I came to the National Health Law Program. And I had 2 of my 3 kids while I was a legal aid attorney. I had doulas at both of those births. And I know that for the first birth in particular, I was giving birth at a teaching hospital. And I think it was like a first year intern, actually. It was an intern who was an intern OB. And I think at the time, it was, I think they had wanted to do an episiotomy at the time. This was a few years ago where, maybe episiotomies were a little bit more common maybe than they are now. But I sort of felt like I didn't need one. My doula was there. My partner was there with me as well. And the doula really helped my partner and I to kind of advocate for saying, if at all possible, I'd really like to avoid that. The OB ended up doing some other things and it was fine. I didn't have tearing and I didn't need the episiotomy. And I think in the big scheme of things, an episiotomy maybe doesn't seem like that big of a deal, but we also know that when it comes to hospital birth, sometimes one intervention can lead to another, and it can sort of have a cascading effect. I've had a number of friends and family members who had sort of very regular, sort of like very normal pregnancies, but because of various issues, ended up having to have emergency cesarean births. And so I think for me, especially because I was a legal aid attorney at the time, it was very obvious to me kind of how helpful the doula had been for me. At the same time, I'd paid out of pocket something like $1,500 for that doula to support me during that birth. And so it was very obvious how helpful it would be for many of my clients in legal aid to have that same type of service. But so many of them, couldn't afford, there was just no way they would be able to afford kind of the going rate for a doula care, especially in the Bay Area, which is where I was living at the time. So when I finally started at the National Health Law Program, where a lot of the work traditionally has been around supporting access to Medicaid services, Medicaid benefits and services. Our director of reproductive and sexual health at the time sort of asked if there were particular projects I'd be interested in working on. And so I had pitched sort of looking at Medicaid coverage for doula care. And so I think that's been great. I think the organization has been super supportive in kind of looking at these issues. And so we've, done a couple of reports. In California, we've been working more specifically around advocating for, and then now implementing Medicaid coverage for doula care in California. And then super exciting, there's a number of states, including California and Illinois, I want to say maybe 6 or 7 states that are in the process of implementing Medicaid coverage for doula care right now, like sort of this year, 2022 to 2023. So I think super exciting to see some of the work that's happening nationally. And I guess just to back it up in terms of doula care, I'm sure Tayo can talk a little bit more about this. But I think one of the things that it's sort of one among a number of different interventions that have kind of come to the forefront in terms of ways to address maternal mortality, in particular racial disparities in maternal health. I would say the other one, which I can talk about a little bit later, is expanding access to kind of 12-month postpartum coverage. So, instead of Medicaid ending that sort of 2 to 3 months after pregnancy for those who are on Medicaid, for those who are eligible for Medicaid because of their pregnancy, a lot of states are also now rolling out Medicaid postpartum coverage to the full 12 months after the end of pregnancies, which actually really tracks a similar coverage sort of I think it's deemed newborn coverage, which has been in place for many, many, many years for children who are born to people who are active on Medicaid at the time that they give birth. And that's it from me.
I'll direct the question to Tayo next. So just to rephrase the question is, just can you please briefly discuss your work, what brings you to your work, and how does your work address issues of maternal and infant health?
For sure, Amy, I just love being able to follow up behind you because you really laid all that good groundwork for me. So I've got 4 kiddos, y'all, and it is 100% like me and my work. So I've had 3 of my 4 kiddos while being a doula and being involved in birth work. So the first one was kind of like, yeah, this is what I'm going to do. And then the next 3, I've kind of just taken step by step in learning what I need to do different. And then also at the same time, I'm like, hey, you pregnant? Okay, this is what we're going to do to fix these things. So I became a doula in 2018, but I started Chicago Birthworks. We started doing like birth work and community organizing in 2017 when I was pregnant with my second kid. And that's when I became a WIC-trained peer breastfeeding peer counselor. And let me tell you guys, I worked in Gary, Indiana, and I was like, this is all on me. Like, I'm the only person you guys are coming to. So I was supposed to help folks with navigating breastfeeding education prenatally, and then some type of like light lactation support postpartum. I was helping people develop their birth plans. I was helping people recover from birth trauma. I'm like, y'all don't have doulas? Y'all don't have anyone else to help you around these things? And so I'm like, I can't even help you breastfeed because you're recovering from so many other things that are impacting this. So that's when I knew that I needed to jump out there, but I'm like, I can't do this by myself because I might drown. So I'm like, mom, come with me. So my mom and I, we started Chicago Birthworks together. And really the biggest reason that I did it with my mom is because she was the game changer for me. And I recognized that everyone doesn't have that specific maternal figure, but everyone can have some type of game changer like that in their life. So my mother was, she mothered me, but in the realest sense, she held me accountable. She brought information to me. And she also gave me space to kind of drive my own vehicle. And that's kind of what we do as doulas, specifically as Chicago Birthworks doulas. We have like a specific model of care where we're not trying to advocate for anybody. So people say this very often, that doulas want to advocate for you. I don't want to advocate for you. I want you to live in a space where you feel confident and competent to advocate for yourself. I want you to be without me and say, no, I want this. Not, oh, I wish my doula was here to ask for these things. And seeing that my mom was able to do that for me, I had 2 in-hospital, very low intervention inductions and it's very unlikely. It's very unlikely that your induction just turns out to be non-typical. I mean, I had no Pitocin, y'all. Like, it was so easy. I got Cervidil and I had a baby 7 hours later. And I'm like, what? This is magical. And I realized it's my mom. It was my mom. She created such a safe environment for me. She actually helped me walk through some of the choices that I wanted to make around my induction. I didn't need to be induced. And it was very comfortable. It was comforting for me to be able to talk to my mom about that and say, I know that I don't need to, but I feel empowered to request this induction. And I think that was a huge part in why my body was able to kind of go along with things. And so that's kind of the model that we try to bring to our families. Do you feel comfortable with everything that's happening in your care? And do you understand it? If you don't, there's a chance that if your mind and your body are not aligned, we're going to see some type of hitch. And I think for us, we've seen that that is a really small and kind of under-acknowledged area that doulas can make a huge impact in terms of the outcomes we're seeing. We don't have to look at, you know, why inductions are failing if doulas are saying, hey, these people are scared. They don't want to be induced, and they also don't understand why this induction would be recommended or what's going to happen. So if a doula could be the person who walks you through each step and explains to you in a way that makes you feel confident why this induction is going to be the best choice for you, or why this specific medical procedure is going to be the best choice for you, maybe we can track and see that there are improved outcomes for, you know, those types of procedures. And this cascade of interventions, I think that doulas can play a huge role in kind of like cutting off some of those things, jumping in there to say this intervention is good and this one is enough, if you understand the use of it. So I say that I see myself in all of this work because as I continue to have children, I'm like, well, I'm never going to have a baby in a hospital again. I know that. So my last kiddos were born at home. And as I've navigated that journey, being a young Black mom who's married, college educated, I'm like, wow, I'm facing tons and tons of challenges. I cannot imagine what folks on the other sides of this plane are going through. And so a lot of our work in Chicago Birthworks is about creating a type of collective community where married folks, unmarried folks, trans folks, non-binary folks, everyone can come together and say, hey, we're gonna all be accountable for making sure that we all make it out alive and that we're all thriving on the other side of this pregnancy. So that's our model. That's kind of how I came here. And I'm really, really excited to talk about this stuff, y'all. I hope that you all get the questions answered that you want and that we're able to provide the right type of context to everything.
Thank you, Tyra. That was great. Robin, can you please tell us more about your work, what brings you to your work, and how disparities in maternal and infant health are raised in your work?
Jessica and Crystal, let me first of all start by saying thank you. I mean, it's wonderful, and thank you for allowing people to turn on their videos, because there is something that about seeing the people or the person that you're talking to and talking with, I should say. So welcome to everyone. Thank you, Crystal and Jessica, for this unique opportunity. And I'm excited just to be here. After last but not least, let me just say this. I started this journey a couple of decades ago, and it's taken various courses, but I started it knowing that as an African American in the heart of the city of Chicago, with a supportive mom, and kudos out there to the moms, I needed to be a part of making a change, being a role model for others who look like me, to say, I can do this too. And this doesn't mean necessarily, for me back then, this didn't mean medicine as such, but this means I can advocate for myself. I can explore what's best for me. I can do my best. I can, if obstacles are in the way, I can navigate around it. I can be supportive of others who've had experiences like mine. So over 2 decades ago, I wanted to make a difference. And I wanted to make a difference in my community. And so for me, it happened to be medicine. And during this journey, I can say it's been very rewarding. It's been a lot of hard work. It will continue to be a lot of hard work, because there's a lot of things that need to be done. And that's why when I look at your young faces, I am excited, all right? I just want to say, I can't say that enough. I say that because I'm the chair of the Maternal Mortality Review Committee, which is part of Illinois Department of Public Health. And in this role, and I've been a member of this committee for over 10 years, but in this role, let me say, give kudos to our state. We were one of 2 to understand how important it is to review and look at maternal morbidity and mortality. So back in the day, and this committee has been around for about 20 years now, back in the day, across the country, this wasn't done in a standardized fashion. And Illinois was one of 2 who decided that this was important enough that we needed to convene the right people and discuss and look at our maternal mortality. That being said, I am proud to say, if we look across the country 20 years later, some would say, why did it take so long? But that's okay, some things take time. There are over 35 states now that have a formal maternal mortality review committee. So I'm giving kudos to our state for being number one of the first. I'm stating there's still a lot of work that needs to be done. And I'm stating that in partnership with the CDC, Illinois Department Public Health has said maternal health is a priority. We need to make a difference. We can make a difference. And with your help, your meaning everyone that I'm looking at today, things will be different. I know they'll be different. And I'm saying they're going to be different in less than 20 years. So thank you so very much. And oh, by the way, I'm a practicing obstetrician and gynecologist.
Thank you, Dr. Jones. That was amazing. Amy, so my next question will be directed to you. You alluded to this earlier, but the Build Back Better Act, just to add a little bit more context, addresses maternal health. One aspect of the act is that it now requires all states to extend Medicaid postpartum coverage to 12 months permanently. Under the American Rescue Plan Act, states were simply given the option to extend the coverage for up to 12 months or up to 5 years. So can you go a little bit more into the significance of extending postpartum care for 12 months, how this aims to address morbidity and mortality, maternal health disparities?
Yeah, for sure. And I will say, in terms of the Build Back Better Act, I am hopeful that it will continue to move, but it has been stalled for some time. So I think, we'll have to see if that does push forward. I think it was great that there was a part of the kind of Medicaid postpartum coverage that was covered, that was included in the American Rescue Plan Act. And it would be great if it became, if that Medicaid expansion became mandatory, if Build Back Better does kind of continue to move. But in terms of the Medicaid postpartum coverage, as I mentioned earlier, I think this is one of the pieces that we've seen a lot of states pick up, in addition to kind of efforts to expanding access to Medicaid coverage for doula care. I think, as I alluded to earlier, it used to be that in order to qualify for Medicaid, you typically have to fall into a certain category, right? So in addition to being low income. So it used to be that, you had to be a child, a caretaker of a minor child, an older adult, you have to be a person with a disability. Not all states have expanded Medicaid. And so one of the big things with the Affordable Care Act was this opportunity for states to expand Medicaid to basically single childless adults. And I would say in terms of I think that the kind of idea of expanding postpartum coverage kind of is another type of potential Medicaid expansion. But this would be particularly expanding the Medicaid, the length of time for Medicaid coverage for those who are eligible for Medicaid based on their pregnancy. So, and the reason why I kind of want to go into these details is because some people become pregnant and then become eligible for Medicaid, and they continue to be eligible for Medicaid even after the end of their pregnancies, because they're now eligible as, based on their income, because they're caretakers, because they're part of a family. There may be other categories of coverage for which they continue to be eligible, but that is not the case for everybody. So in some cases, and in all states, there's still a small sort of subset population of pregnant people who end up falling off coverage and are no longer eligible after the end of their pregnancies. And so it used to be that the amount of time, if you were eligible for Medicaid because of your pregnancy, you continued to be eligible for anywhere from 2 to 3 months, depending on when in the month your pregnancy ended. And the expanded postpartum coverage is basically saying that at the end of your pregnancy, you continue to be eligible for 12 months, basically for that full year. As I mentioned earlier, for many, many, many years, Medicaid has provided what's called deemed newborn coverage to the newborns who were born to people who were active on Medicaid at the time of that child's birth. And so for many years, the United States has provided kind of babies with basically that 1 year of coverage, regardless of changes in income, regardless of changes in assets. And so in some ways, this kind of expanded Medicaid postpartum coverage is just giving to the pregnant person the same thing that we've been giving for decades to the babies who are born to that person. And then I would say in terms of addressing maternal mortality, I think, as I might have mentioned earlier, in some cases, some of the conditions that are leading to maternal mortality or to severe maternal morbidity, some of those may come up within that 2 to 3 months after pregnancy, right? But many of them do not, right? Many of these are issues that maybe start during the pregnancy or maybe start in those, initial months after pregnancy, but maybe they don't really become a serious issue, which is something that where you would kind of finally go to see the doctor about 6, 9, 10 months after the end of that pregnancy. And so that expanded postpartum coverage is really giving pregnant and postpartum people that continuity of coverage that they need during that extended, extended postpartum period, or that extended period after the end of their pregnancies. They can continue to see, hopefully the same doctors. They can continue to get the same medications. They can continue to basically have that expanded coverage that otherwise, as I mentioned, for that subset of pregnant and postpartum people, that coverage might otherwise cut off. The other, and I guess the sort of final interesting thing that I'll say about this is that in some cases we are seeing states that are rolling out both the Medicaid coverage for doula care and the postpartum kind of 12-month postpartum coverage at the same time, like in the same state. And so one thing that I think is interesting is we are seeing in some states an effort to really have kind of an expanded period of time for that postpartum doula care too, right? So like, can you have postpartum doula care or like some kind of postpartum support, if the doula is willing to provide it, and if the Medicaid enrollee wants it, for that whole 12-month period to really track that 12-month Medicaid postpartum care too. So that's something also super interesting and something that we'll definitely be tracking.
Thank you, Amy. I know Dr. Jones-Robin had something to add. I have a question for you after that, but I would like to hear your thoughts.
So it was in the chat, but I'd like to give a shout out to Illinois. And the reason I want to do that is because we're one of the first states to expand this Medicaid coverage to 12 months. And let me say this, the Maternal Mortality Review Committee, it reviews maternal deaths, unfortunately. With that being said, we found that up to one third of the deaths occurred outside of the traditional postpartum period, outside of that 60-day period. So we had to advocate for, speak up and say, we need coverage beyond the traditional 60 days, and they heard us. And that's why, another reason why this committee, the review of the cases, the bringing forth of important data is so significant. So in Illinois, we're there. And every time I say we're there, I have to add, but we have a lot of work to do.
Thank you, Dr. Jones. On that note, I have a few statistics just to set the stage for everyone. So pregnancy-related mortality among Black, American, Indian, and Alaskan Native women are over 2 to 3 times higher, respectively, compared to the rate for white women. Every year, there are over 40.8 Black maternal deaths, 29.7 American, Indian, and Alaska Native maternal deaths per 100,000 live births. That is compared to 12.7 white maternal births per 100,000 live births. Racial disparities for these groups increase by maternal age and persist across education levels. These disparities persist even when controlling for insurance status, income, and age and severity of conditions. Can you please explain a little bit more about what the main risk factors are for these disparities?
You didn't say who, but I'm going to jump in and just assume that you're talking to me, okay?
Yes, that was for you, Dr. Jones.
Let's just start by saying not all women are at equal risk in dying in the United States of America. And that should cause all of us to pause. And if you didn't pause, then you didn't hear what I just said, in my opinion. There's been a deafening silence around increased Black, brown maternal mortality rates. And in order to understand why there's an increase with Black, brown maternity rates, you have to dig into the history. Now that's a conversation or lecture in and of itself. But in your spare time, look at the history of how Black, brown women have been treated or mistreated, from anything from childbirth to having a voice as it relates to their bodies. Go back, history will tell you. Let me continue by saying it's important that you also realize that when you're looking at pregnancy-related maternal mortality, in particularly as it relates to medical conditions, in our state, Black women are over 6 times as likely to die as their white counterparts. That should also cause you to pause. I want to make it clear, this is not due to a woman being Black. It's not due to a biologic factors involving her race. That's not what it's due to. So I don't want anybody to be confused on that issue, please. While health insurance, availability of services can be a major barrier to care, there are other social and systemic factors that affect this health gap that we're seeing across our country and in our state. While some thought that health was a little entity that lived in a community all by itself, I think we know now, and if we don't, we will by the end of this conversation, health doesn't exist in a silo. Health is not just genetics. A woman's health or a person's health is influenced by a myriad of other factors. And those factors include anything from poverty, racism, education, housing, childcare, transportation, violence, neighborhood safety, and the list can go on. It's important that we talk about and that we acknowledge that racism, classism, sexism, and other social inequities have played a role in the disparities that we're seeing in maternal health. Race is blamed, but I stated earlier, race is blamed, but it's racism that plays a role. Given the increase in the maternal mortality rate over time, particularly in the United States of America, we have to discuss, we have to acknowledge that there are other factors that are playing a role other than health with this increase. And let me state, and I'm gonna state it loud and clear, this is a public health issue. It's not just my issue. It's not just Allie's issue or Kate's issue. It's our issue. And as such, we all have to be champions to narrow and hopefully eliminate the gaps.
Thank you, Dr. Jones. My next question is for Taya. So mothers who have received doula care compared to mothers who have not received doula care, who have a considerable risk for adverse birth outcomes, reported that they were 2 times less likely to experience birth complications, 4 times less likely to have a low birth weight baby, and more likely to breastfeed, and also just more likely to be overall satisfied with their care. Can you explain the role of doula care and how a doula might interact with the hospital?
Absolutely. First, I have to say there was a reason why I grabbed this shirt out of my laundry hamper. My shirt says postpartum is forever. And when we talk about like the expansion, I'm like, 3 months. No, the rest of my life. I hope to be taken care of for the rest of my life. After I give birth one time, like you just said, Dr. Jones, like our health is so robust. And I am likely, not me personally, I don't want to have any more children, but the first time I have a child, I may give birth again. And so if I'm not looking at the entire continuum of my life, then my healthcare providers or healthcare institutions can't say that they're really truly providing me robust healthcare, because each pregnancy has the ability to impact my body in a way that may impact the next pregnancy. So you cannot, support me throughout my pregnancy, throw me to the wayside, and then hope to fix some problems the next time that I'm pregnant. So throw it out there really quick. In terms of how doulas are impacting folks' birth outcomes, it's always like above me and beyond me when people are like, I couldn't have done this without you, Tayo. I'm like, you absolutely could have. I sat over here in this corner and I rubbed your feet occasionally. I think that the biggest thing that we're doing is bringing kind of these mid levels of information. So I can't tell you how many times I attend a birth in a hospital. We've got maybe abnormal contraction patterns, and my nurses are like, yeah, you know what? I want to get things moving, but doula, do you have any ideas? And I'm like, wait a minute, do I have ideas? You work here and you were here before me, right? I've had midwives ask me, do you have any ideas? And I've realized over the years that we do have a ton of experience in the very non-eventful births. So if you've got a low-risk person birthing in a hospital, a doula probably can really, really help them, because most of the staff that they're interacting with, they don't have experience with non-eventful, low-risk vaginal births. They're like, I don't know. I mean, it looks like you're contracting, like move around. My favorite thing that nurses say is like, you want to try some movement on the peanut ball? The peanut ball is not the answer to everything. Everyone doesn't need that. So we come with a whole lot of kind of hard-earned knowledge. So we're not clinicians and we don't have clinical tools to be able to assess what's going on. We have to use our head. We have to use our hands. We have to use our heart. So we've got this really like tactical skills-based knowledge. Like, hey, you know what you need? You might need to consider getting an enema. Have you gone to poop? Because that poop can be holding things up. Are you feeling extra nervous? Do you want me to call your mom? Or let's think about some of the people. This is one of my favorite things to do with folks. I ask them to name the women or the people in their family that they feel have had very strong and powerful births. And if they feel like I don't have anyone to connect to, this has to be you. And I ask them, who do you want to reach back? Do you want anyone in your family to think back and say, it was Crystal? Crystal is the one that had an amazing birth, and I think about her. I don't know if you want to have kids, Crystal. But these are just small things that we can do, right? That can really change outcomes. If I know that a baby is likely, I've known this mom throughout her entire pregnancy. She always tells me that the baby's on this side. And I'm like, maybe your baby is not fully engaged in a really optimal position. And I know that because I've touched your stomach time and time again. You're telling me that you're having pain on this side. And I want to get you into this position that can get your baby engaged in a much more optimal way. You're not seeing nurses or residents or even obstetricians coming in to do these things. So doulas, we have this like really golden knowledge. And the truth is, I think we're not really being utilized in hospitals the way that we need to be. I can say that I either get like one of two things where I'm like, y'all want me to do everything here, or folks are like, oh, the doula, aren't you here to rub their feet and offer them ice water? So I think that we have so much room and space for us to work together. If we look at like what the needs are across the board, we have a lot of folks who need care, and we don't have enough providers to provide one-on-one high quality care. But there are a lot of doulas, and there are a lot of birth workers who could fill in a ton of space. If I've got a mom who looks like she has hypertension and she's not really at a place where she's had the opportunity to establish good trust with her provider, and if her provider is saying, you look like you got hypertension and here are the steps that we want to take, the doula gets to say, hey, look, listen to me. We've established this trust, and I can walk you through what will happen if you move along with the recommendations that your provider is sharing with you, you know? And that gives me the opportunity to be a part of their care team, to be a part of, hey, this is what hypertension can look like. These blood pressure readings, this is not safe, and this is not good for you. But if we're not regarded as someone who can assess those things, it's nothing. It's no type of clinical action for me to help someone understand what their blood pressure reading is. But these are not things that we're seeing in terms of the collaborative or integrative care models, you know? So outside of doulas, there may be midwives, there may be out of hospital midwives that can be integrated into these care systems. So I would say our role, we are trying to figure it out. We're trying to figure out how can we show respect to the experts who have years and years and years of experience and who truly are stretching themselves across. Can you imagine being responsible for a dozen pregnant people in labor? Can you imagine that? That would like scare the heck out of me. So there are folks who are putting themselves in those situations and have to bear that weight, and doulas want to help. If we can be there to take one of those people into our arms and say, we're gonna watch out for this person, and if there is an emergency, I will call you. We wanna do that. And that would mean that hospitals have to show support for folks working with doulas. They have to. They have to ask those questions. Do you know what a doula is? Do you have access to finding doula support services? Are you comfortable with the doula that you're working with? Because we want you to have that. We know how important continuous care is throughout your labor. Someone should be with you. There should be no point where you and your partner are looking at each other clueless and you're in labor, you know? So I think hospitals, they can do more. And like you said, Dr. Jones, we got a lot of work to do. We really do.
And can I say this to you? You're very modest because, and I'm saying this as an obstetrician, your role is invaluable. You know, this rubbing of the feet, and I'm not saying that that's not important, but your role is so much more. Your role also, and I've seen it, is advocate. Like you just said, you know, the advocate speaking up or helping that birthing person to speak up. And I'm here to say, ideally, we would function as a left and right arm, because in the center of those arms are the patients. So kudos to you. There's a lot of work that needs to be done, because what we really need to do, and we're working towards this, Amy said, I think you said $1,300 to $1,500. Well, the average person does not have $1,300 to $1,500 for a doula. I'm not trying to shame Amy. I'm happy that she was able to do that. But so we need to, this is where everyone on this call comes in. We need to impress upon our insurers that everyone, and this is where equity comes in, everyone should have the opportunity to say, yes, I would benefit from a doula.
Mm-hmm.
Thank you. So following along with that, one of the main drivers behind this conversation was to make sure that we can really equip all of our students with the information that they need to make the change that's going to make an actual change. So this is a question directed to all, but I'll begin with Amy. As future attorneys, physician, and healthcare practitioners, what actions do you see are the most effective way for us to promote reproductive justice at this stage in our careers?
And can I just add, can you guys keep those responses a little bit brief, because we do have more questions rolling in now, and I want to get to the questions of the people that are on the call.
Yeah, I would say briefly, as a lawyer speaking in particular to the law students, I don't know if some of you have been introduced to the idea of community lawyering. I think this is something that I tried to really think about a lot, particularly when I was in legal aid. But I think as lawyers, you often come in with a lot of specialized knowledge, and I think it can be easy to kind of really have a top-down approach and say, oh, I kind of looked at this issue, and I think this is what you all need as a community. But I think I really encourage you all, to really think of it as more, kind of see a community or issue that you want to tackle and really go to those who are affected and ask them what kind of support they need. Ask them if you can be helpful. Do you even have a role here, or would your work, or would it be more helpful for you to kind of find your work, or would it be more helpful for you to do something else or help support in another role? So I think I really encourage the lawyers to, in some ways, definitely use your tools for good, but be strategic and also make sure to understand that for most of these issues, your role is really maybe going to be more of a support role and not a leadership role, and to sort of explore what that looks like.
Can I jump in here? This question was for everyone. Okay, so I have an aunt, y'all. I'm like all storytelling here. And she was my mom's youngest sister. The immediate next one, rather. She wasn't youngest, the next sister after her. And anything that I couldn't get from my mother, I'd get from my aunt. And my aunt wouldn't do stuff for me that my mom would do. She would just pay for it to be done. So I'm like, I really want to go on this trip, and these are the things that I need. She's like, look, I won't come and do that, but I'll buy it for you. And my aunt just passed away. And what I thought about was how much she didn't like doing the motherly things that my mother would do, but she wanted to see me succeed. And she said, if I have the resources to remove any barriers, I'll do that. And I'll do it over and over and over again. So if you find yourself in a place where reproductive justice seems like, I don't know how to do that, figure out what barriers exist and just work on those things. Work on what you can. And if your contribution is not money, it can be your time, it can be your work. Look at what barriers in the area or within your skill set can be removed. There are tons of things. I think someone shared in the chat, Nadia, you shared about the Birthrights Bar Association. There are tons of things that you can learn about the laws, the policies, and in some ways, some of just the practices that are harming Black birthing people and birthing people across the country. And if you see yourself never becoming a doula, that's okay. If you see yourself never becoming a medical provider, that's okay. But all of us here have a parent that gestated us. And hopefully that lends us to understanding how important it is that we repay them in the smallest by making sure that if we have an opportunity to change a policy, that will trickle down and trickle down and trickle down to people being able to have dignified births. Do those things and focus on them and feel confident that you're making change in those areas.
Thank you, Tayo. I want to make sure as we direct the questions that I share the emails of all of our presenters today. We can talk about this for hours and hours and hours. So I want to make sure that I share that, and I guess I'll direct it to Jessica if there are any questions that particularly stood out from the chat or anyone wants to.
Yeah, there are a lot of questions in the chat, and so I expect, some people have sent them to me privately, so I expect, you guys will hopefully be able to connect with our lovely speakers and ask some of the questions that unfortunately we're going to run out of time to do. But the question that I think is important based off of what Dr. Jones mentioned before, and also what Amy was talking about. So this question is directed at both of you. From your perspective, how can medical professionals balance regulatory concerns and legal issues such as medical malpractice with patient advocacy and birth? Oh, Amy, you're muted if you're talking.
Oh, no, I'm actually just like reading it over in my head.
Oh, okay, yeah. So the question is about how medical professionals can balance the regulatory concerns and legal issues such as medical malpractice with patient advocacy and birth. I think when we talk about insurance and legal issues, it can get complicated. So I thought that that was a different question from the others.
Did you want to answer that first, Dr. Jones? Do you have thoughts or?
I have thoughts. We cannot ignore malpractice. Otherwise, we'd have our head in the sand. All right.
Right.
But we have to talk about it and vote about it. Vote in the right form. We have to look at policies. We have to look at laws. we have to look at the needs, and we have to vote for what's in the best interest of the patient, getting the number of providers up so that people will be more attracted to this field. And when you lead with empathy, when you lead with compassion, and when you serve with empathy and compassion, you realize that no, you don't want to be sued. You realize people currently have the right to sue you for almost any reason. But when you know that you're leading and serving for the right reasons, you're voting for the right things, i.e. to take a look at malpractice reform, then you go into what you're passionate about. You go into what you're passionate about, because that's going to lead you, that's going to have an impact on making all these things that we just talked about different than they were 10 years ago, or different than they will be 20 years from now. Amy?
Yeah, and I would, I'm not a medical professional. Obviously, I also don't do medical malpractice law, but I mean, I do know that, in some of my conversations with, with OBs, with nurses, and other, other kind of other like medical folks on the labor team who are supportive of doula work, in particular, I think many of them. I think many of them feel like there is a balance between, between having their role as kind of the part of the medical care team, but then also understanding, say, the benefit and being able to work in partnership with a doula who is there supporting the client. So I don't necessarily see those two things in, I don't necessarily see those two things in conflict, but I also, acknowledge how in some cases, if the doula is there, if the doula is there kind of advocating and giving their client the tools they need to best advocate for themselves, sometimes that might, you can envision some situations in which that does run up against, kind of put you in conflict with the medical care team, right? One thing that I try to keep in mind as I do, kind of try to provide the support around expanding access to doula care is that, while I do think doulas have a really great and significant role to play when it comes to addressing racial disparities, I also acknowledge that you can't put this all on the backs of doulas, right? So, for example, one of the big reasons why doula care is being pushed to address racial disparities is because they can really help clients, in the moment, kind of respond to things that are happening, whether it be individual racism, structural racism, or institutional racism, right? Like doulas can really help that client problem solve. They can help the client, address their needs and sort of, get their needs heard and get their needs taken care of. But at the same time, what you're acknowledging implicitly is that you're throwing doulas into this racist system, right? And, no matter what, like the individual doulas might be able to kind of address things on a one-on-one basis with their clients, but unless you're doing something to address the broader systemic and institutional and structural racism, the racism in, the birthing facilities and, everything else that the pregnant people and the doulas are facing, you still have this kind of broader systemic issue. So, I mean, I feel like that's really, and as long as that happens, I mean, yeah, you're going to have medical malpractice lawsuits because there's these racist things happening, right? So I don't know, like, I feel like I totally get where the question is coming from. I don't feel like those things are always in conflict, but because this is the world that we live in, and things are happening to people in hospitals and elsewhere that shouldn't be happening. I think that's going to continue to happen. And I feel like this is also part of my broader thing of of like lawyers sometimes make things difficult, right? Like lawyers sometimes make things more difficult. And I think feel like medical malpractice is sort of one of those things where maybe this is kind of the case.
Yeah, the reason why I thought that question was interesting is because a lot of times that's something that practitioners, clinicians, MDs talk about, right? And I think sometimes people maybe use that as the reason for not doing something or for doing something, right? And so I think it's important, like Dr. Jones said, we do have to talk about it. We only have a few more minutes, and so I don't know how briefly anyone can answer this question, but there are a few men on the call, and I wanted to address their question about what non-birthing parents, especially men or MAS folks, can do to support and be positive for can do in supporting positive maternal and child health outcomes, either through practice or policy. And I do think it's important to talk about how men, everyone's a woman on this call right now, but like Dr. Jones said, everyone should get involved to address these issues. So does anyone have something? And I apologize to everyone on the call if we go over just a little bit, but
I would love to jump out there.
I was gonna say, I think Ty would be the best, honestly. So great. Okay.
So my last kiddo is 11 months old. I'm still I feel like I'm freshly postpartum. I feel like I had a baby yesterday. And my husband has grown tremendously through our collective reproductive journey by acknowledging that I am individually having a birthing reproductive journey, but he is also reproducing with me. And so in the ways that we have united, he's taken a certain level of accountability to know that if this person is going to help me reproduce children, I'm responsible for her health. I'm responsible for making sure that she has her basic needs met. I'm also responsible for making sure that I support in removing any barriers to her being able to access care that I can't provide directly. And so I'm just going to say, frankly, like the excuse of not knowing is not enough for non-birthing people. That could be your partner or whoever else. It could be your parents, siblings. It's not enough for you to say, I don't know. You must then say, there is someone who does know, and I need to make it very clear for you to get to that person. It makes a pregnant person or a postpartum person feel very unvalued if the people around them that don't do the physiological work of carrying, gestating, birthing, and sometimes feeding a baby in the postpartum time, if the people around you are not working like double time, okay? So all I gotta do is walk. I wanna be walking on a path that is cleared so that I can get directly to the care that I need. Don't make me shovel my own pathway. And that looks like learning what those barriers are. That looks like learning what any of these risk signs are. It looks like sometimes advocating for yourself as a non-birthing person to say, hey, I need some help over here. I'm not understanding what my partner is experiencing. And I'm not understanding what some of these things might be implicating, I think that we have, Dorothy Roberts said this in Killing the Black Body, but the maternal fetal complex, I think, is something that is so severely ignored, that the idea that the mother or the birthing person and the baby are not the same. They are one organism, they are one dyad, and when you separate them, it leaves that birthing person, that postpartum mom, to fend for herself. And so the people who didn't give birth to that child, you have a sort of superpower to see things in a way that this pregnant person cannot. And really, I think it starts with just learning. Figure out these basic level things and do some work to remove those barriers. I think that's like the biggest thing that you can do. If you don't know how to fix this, you know how to call 911. That's called removing a barrier, okay? I don't know why she's bleeding, but I'm calling 911 because somebody else can fix this, and you have to be willing to do those things for your partner, and I say advocating for yourself is a huge one because you are also in a reproductive journey, My husband used to always say that he's like, I'm postpartum. I'm like, you're not postpartum, you're postnatal. You're postnatal, I had the baby, okay? And I ignored for years that he was going through a reproductive journey with me. So once I started to accept that, he was able to get care, which allowed him to show up for me. And that way, I hope that's helpful.
Yeah, I think that's great. And again, I just want to respect everyone's time and especially our speakers. So I'm going to turn it back over to Crystal so we can close it out. Thank you all so much for your questions. I'm so sorry we didn't get to them because there were many questions.
I just want to thank you all, especially our speakers, for our time. We could not ask for better synergy, more wonderful perspectives all melded together. This has been so insightful for me, and I just thank you all for joining us today. As you see, our speakers are willing to speak to you all continually, or your emails are here. Thank you all for joining today.
Yes, thank you so much. This video will also be uploaded to the White Coats for Black Lives YouTube, and we'll be sending that out in an email to everyone who attended. So sorry that we went over, but thank you all so much. Thank you, thank you.
Thanks, everybody.
Thank you.